Hi everyone. So today we are going to be learning about how we actually perform an exam, some of the major steps that we have to take when we're dealing with our patients. And then also we are going to be learning about our controls and what all of those little buttons on our machine does to our image, how we can adjust them. When we adjust them, what does that do to our overall picture? So we have talked a little bit about some of those basic controls in lab up until this point, but we're definitely going to be taking them a step further, and I will start to expect you guys to be aware of these controls when we are in lab from here on out. So we're going to be starting with how we perform our exam and some of those major steps. One of the very first things that we have to do as soon as we get our patient into the room is we have to confirm with our work list or our schedule. So we're not just pulling people in from the waiting room or from the ER and we're just kind of scanning them, for no reason, or a doctor calls us and says, hey, can you do an exam on this patient? We have to make sure that there is a correct order, that the patient's information lines up, we have all of their correct demographics, and that they're put into our system correctly. So those are all things that happen kind of behind the scenes when a provider is putting in an order for an exam. Now we have to make sure that that exam type aligns with what we are looking for. So if our patient is coming in with abdominal pain, and the patient's order from their doctor says that we should be performing a thyroid exam on their neck for abdominal pain, we have to double check that. We have to say, okay, like the reason on here isn't matching up with the exam that you want done or with the patient's complaint or issue. So we always have to kind of double check our schedules, double check our work list, and make sure everything is lined up appropriately. So on our systems, we are going to have a DICOM sort of organizational platform. So what DICOM does is it kind of like keeps all of a patient's information together. You'll definitely learn more about this in one of your Medi courses, but it kind of keeps everything aligned so that everybody within the healthcare system can reach that patient's chart. It keeps all of their imaging together. It keeps all of the important things for radiology together. So we're using a DICOM sort of system pretty much wherever we are. You are going to have this on your work computer. So this is what you are going off of. This is kind of how you see your schedule for the day. And then that is hooked up to or compatible with what is going to come up on our machines. So we have a schedule that we follow from DICOM where patients kind of get put in and entered. And then we have that kind of transfer electronically to our machines so that when we go into the room with our patient, we can pull all of their information from that DICOM computer system to our machine itself. So this is pretty much what the standard schedule or what a standard DICOM work list would look like. And then you are still able to pull that on your machine once you're in the room with the patient. So once we are kind of confirming our work list, confirming that the exams on our schedule make sense for the reasons, we have an order from the doctor, there are certain things that we have to double check and make sure that if there's any missing information that we know how to go about finding it. So what type of exam are we performing? Why are we performing this exam? When is the patient going to be scheduled for this exam, or is the patient even scheduled for this exam? Does the patient have any previous medical imaging, whether that be reports from previous exams or the actual images available? It's very, very important for us, especially to be reviewing images if we have them. And if we don't have them, it's important for us to understand the terminology that we can find on a previous report. A lot of patients will come to us as a follow-up from mammogram or as a follow-up from MRI, where they see something on those exams, but they need further detail. And ultrasound can provide that detail. But if you're not aware of what T2 or T1 means on MR, then it's not really going to help you that much. You're not really going to know where to look. If you're not familiar with the segments of the liver or how that should appear on a CAT scan, when we're following up from a CAT scan on that liver, we're not going to know where to be looking for that cyst or be looking for that liver mass that they found. So as we go through and we learn about specific pathologies, we learn about specific organ systems, I will try to throw in as much information pertaining to other modalities as possible so that when you guys are looking at images, you can use that as helpful information prior to going into your exam and kind of the terminology that you would be looking for on a report. MR terminology, CAT scan terminology, mammography terminology, they're all different than ours. So you have to be aware of what those key words are, because we are the ones who are usually providing secondary information. Those exams, those modalities are typically first type of exams, or maybe they find something incidentally, and then we have to go in and provide further detail. So we can't rely on a machine to find it for us. We have to know where to be looking. Does the patient have any additional health information that we should know that could be useful to us before or while we're performing that exam? So have they had any history of surgeries, any abnormal blood work, any history of cancer? All of those things are going to make a difference to us when we're scanning, especially if we find something and we're like, ooh, what is this? You know, if we have a little bit more background knowledge on that patient, we'll be able to place those puzzle pieces together a little bit more easily. So how do we prepare our room? So you want to make sure that before you even get your patient in there, that the machine is turned on. There is nothing more awkward than pulling your patient into a room and having to wait for that machine to turn on, because now you're making small talk. Maybe your patient's really nervous. Maybe you have a busy schedule that day, and it's all kind of time wasted. So make sure the first thing that you do when you get in is turn the machine on. As we know, it takes a little bit of time for them to boot up, so you want to make sure that your patient is not sitting there waiting for that machine to turn on. You also want to make sure prior to the patient coming in that the table in the room is clean. Guys, I stress cleanliness. This is something that you will be responsible for in lab, making sure that the linens are nicely and neatly organized, making sure that the gel is clean, that the machine is not covered in gel, that we're kind of wiping up after ourselves, wiping up as we go, making sure that everything is clean and presentable for our patients. I'm sure when you guys are patients, you notice those things, so you don't want to walk into a room where there's a big stain on the sheet on the table that you're supposed to be laying down on. So make sure you're aware of these things. Put effort and initiative into being aware of that. Again, appropriate linens, making sure the table has a nice clean sheet on it. Make sure the gel is ready to go, nice and warm. Sometimes that first patient, especially if you're running late in the morning, they may not have warm gel because the machine hasn't been on long enough. So things to be aware of prior. Make sure that the lighting in the room is set to the sonographer's preference. You are going to see that there are some sonographers who like to scan in pitch black. Most sonographers like to kind of scan in a dark room, but maybe a little bit of background light. And then there are some sonographers who like to scan with the lights completely on. I don't know how those techs do it. So we are going to be in the ballpark of that mid-range. Sometimes when the room is completely black, you have unnecessary strain on your eyes from the screen of the machine. So you want to have a little bit of that background light to kind of balance that out if possible. Now in lab, we do have a little bit of glare that can affect our lighting in the room. And we are going to be working on that, getting a curtain to kind of block some of that out so that we are operating in a mid-level darkness of the room. You also want to make sure that the exam table is accessible to the patient. So you want that table to be all the way down to the ground if possible, so that they don't have to struggle to get on the table. And then once they're in there, you can adjust to your height. You also want to be aware of any additional patient identification in the room is not available for the patient to see. So sometimes techs will leave out their printed work list on the desk in the room. That's not appropriate. Sometimes they'll leave the DICOM work list up on the computer. If there is a computer in the room, that's also not appropriate. So you want to make sure that if there's any information pertaining to any other patient other than the one that you are directly working with, that none of that is visual in the room. You want to make sure you're putting all of that away, hiding that, minimizing whatever you need to, because that is a HIPAA breach. So next we want to make sure that we have our correct patient. So again, we're making sure that we have a confirmation of patient information from the DICOM system or the RISC system. RISC stands for Radiology Information System. Kind of very similar to DICOM, just kind of different acronyms that we can use for these different scheduling systems. So you want to make sure you have a direct match. You want to make sure that the spelling of the patient's name is correct. We're not missing a letter. We don't have extra letters in there. You want to make sure that their birthday is correct and complete. We don't want to just say, December, I don't know, just say December 25th, 2023, because are we either scanning a patient who, not 2023, 23, December 25th, 23, because are we scanning a patient who is brand new, a little tiny baby, or are we scanning a patient who is 100 years old? So you want to have full birthdays, you want to have full years, 12, 25, 2023, making sure that we're not missing anything with the birthday. You also want to make sure that their proper gender is identified. So a lot of healthcare systems are still kind of working and operating archaically in the sense of the binary gender, so the standard male and female. They haven't quite caught up to any sort of non-disclosure or non-binary or anyone going through the transition process. So we typically are going off of what that patient is in terms of government legality. So in the system, if we have a transgender patient who is a trans female, if they have not changed their gender with the government, then they will still be in the healthcare system as a male. Now, it's important to make sure that regardless of what is in the system, that you are still communicating with that patient how they want to be communicated with. So a lot of systems now, or a lot of scheduling now, will have the patient's legal name, which could be their previous gender, but in parentheses next to it, it'll have prefers to use the name or requests to use the name, whatever they want now. So that kind of gives you a little bit of notice to make sure that you're communicating with your patients how they are expecting to be communicated with. We also want to make sure that the physicians are matching, so that whoever the patient's doctor is in the system is the one who ordered that specific exam. We want to make sure the exam types match. So again, we're making sure that the exam that we're performing is the exam that is most appropriate for the reason. Patient interaction. So once we have our patient from wherever we're getting them from, if we're in an outpatient facility, we're probably getting them from a waiting room. If we're in the hospital, they're probably coming to us, or we're going to get them in the emergency room. We can also do outpatients in the hospital, so you kind of get a little variety with that. But regardless, as soon as you get your patient, it is very important for you to confirm the ID. You don't necessarily want to confirm their ID in the very public setting of a waiting room, or in the middle of the emergency room where there's a lot of other people who can hear. I personally like to confirm their ID once I have them in the room. The worst thing that can happen with that is that I realize I have the wrong patient, and I walk them back and I get the right patient. If your patient looks like they are struggling to walk, if they look like they are in a lot of pain, or if you have a far walk from the waiting room to the exam room, I like to just kind of whisper to them a little bit privately, not whisper, but I like to kind of pull them aside quietly and ask them to confirm all of their information in a way that the entire waiting room can't hear us. That way they don't have, if I do have the wrong patient, they don't have to walk all the way down to the room and then all the way back for me to get the correct one. There are a lot of patients who have the same first name and last name, so it's very, very important for you to confirm also with their birthday. And then there have been times where birthdays align as well, so you're confirming it with the physician. Those situations get very tricky. So again, we're making sure that we are confirming the ID. Once we have them all set, ready to go, we have all the matching information, the exam's right, the doctor's right, the patient's right. We want to make sure that we are fully explaining the type of exam that we are going to be doing. Imagine if your doctor says to you, I need you to go for this test. You go for the test, they slap some jelly on your belly, and they don't talk to you, they don't tell you anything, and then they say, all right, have a good day. You're like, what the heck just happened, right? So you need to be the one to make sure, you're the one performing the exam, so you need to be the one to make sure that you fully explain it to them and that you allow them to ask any questions if they have them. So if we are doing, an abdominal exam, You want to make sure you're saying, okay, we're going to be scanning around on your abdomen. I'm going to be taking a lot of pictures as we go. I'm going to have you do different breathing instructions. I may have you change position a little bit for certain pictures, and then, make sure they don't have any questions. We do some invasive procedures. We do some very sensitive exams. We do breast imaging. We do scrotal imaging. We do transvaginal imaging. All of these exams require very precise and effective and professional communication. If you're the patient and you see somebody coming at you with the transvaginal transducer, and no one is asking you permission, no one is telling you what's going on, no one is explaining what they're about to do to you, that is a form of assault. So you need to make sure that you understand the exam completely and that you are communicating that effectively. Make sure if they have any questions or concerns, you address them. And be aware that the patient is allowed to refuse the exam at any time. So even if you start the exam, you're halfway through, you're like, oh, this is a beautiful exam, this is so nice, right? They can make you stop at any time, and you cannot question that. So make sure you have that upfront initial communication. Ask the patient about their complaints and the reason for the exam. Make sure they understand why they're there, why their doctor ordered this. Get as much information from that health as possible, but make sure that it's pertinent. Sometimes we get these little old men who are so sweet and they're so lonely and they just don't have anyone to talk to. So they come in and we ask them what's going on, or we ask them about their health history, and they say to us, well, it all started in 1972. And it's like, sir, this is so cute, but I don't have the time for this, right? We have other patients that we have to get to. We have to get the exam going. So you'll learn and you'll see how different texts kind of move those conversations along a little bit, and how they're able to filter what is useful information and what is not. Make sure, especially when you're first starting out, that you write down this information so you don't forget. It's kind of like if you've ever been a waiter, you at first have a really hard time remembering a table's order. And then once you've been doing it for, a couple years, you're like, yep, I got this down. I can remember dozens of orders at once. And, I'm grateful that I don't forget much. So it's very similar when you're first starting out communicating with patients. Patient positioning, this is very important for us. So again, we want to make sure that we are offering communication and assistance to our patients, especially when they have to change. You will see a lot of techs in outpatient facilities. They don't necessarily change their patients into gowns, but that gel kind of gets everywhere. So sometimes if you see a patient coming in a nice business suit or in a beautiful dress, you might want to offer to them to change into a gown. If we're in the hospital, most of our patients are already going to be in gowns. So it's kind of a use your judgment scenario. You'll see techs doing different things everywhere, but you want to make sure that if someone is coming in looking very professional, very put together, they look expensive, you want to offer that they change into a gown so that we don't get gel on their clothes. Typically, those patients are going back to work after their exam. You'll also see some patients that come in sweatpants and a sweatshirt. They typically know that they are, those patients would probably rather not change because it's like an extra thing they have to do. So again, we're still offering that to the patients. But typically if you see somebody coming in underdressed, that's because they're aware of what type of exam they're about to have, and they're wearing clothes that they don't necessarily care about getting dirty. But again, we're always offering our elderly patients, we're always offering to help them. We don't want to assume that they need help, but we're still offering. And then you're asking if they would like a private room, maybe saying if there's a changing room that they can use, or using the exam room to change into their gown. We also want to make sure that the patient is comfortable and modest at all times. So whether we're changing our patient or not, you want to make sure that you are only exposing the body regions necessary for that exam. So this becomes very particular when we're starting to scan breast and we're scanning scrotal. So we'll definitely be coming back to modesty a lot, especially in that spring semester. Ergonomics, very important. You want to make sure that for patient positioning, that the patient is as close to you as possible on that table without the risk of them falling off. So you're bringing them all the way over to you. You're having them scooch all the way over to the right side of the bed. You also want to make sure that the exam table is at an appropriate height for you. We don't want to be extending our arm or extending our elbow so that our arm is away from our body. These are all things that we are going to learn about specifically, but for right now, table height and patient location in terms of positioning is very important for ergonomics. Okay, so here we have our patient information screens. We have our patient ready to go. We confirmed everything. You're like, oh my God, we haven't even started the exam yet. So there's a lot of steps that go into it up front, but very, very important steps. So this is what we're going to see. We're going to make sure that all of this information on our screen matches up with that DICOM work list that we were previously talking about. It should, but here's where you're going to just confirm it, double check everything. You'll see a lot of information on here: first name, last name, their hospital ID, date of birth. The operator is you, so usually you will be putting your initials in that category. When you're a student, you will be using the tech who's supervising you, their initials, and then usually under comments, that's where you'll put student initials. Sometimes they'll have operator. You know, if I was supervising you, it would be EB/ your initials. We have gender on here as well. We have the accession number, which is going to be a unique code only for that patient's exam. We have the type of exam that we have up at the top there. It's under abdominal. And then we have our transducer selection on here. So you'll see some variation of this patient information screen. We have to take a picture of this. We have to save this information at the start of our exam. Okay, so now we are getting one step closer to actually scanning. So now you want to make sure that you have the correct transducer based on your exam type, and we also want to be using the correct preset selection. Once we get into our knobology lecture right after this, that preset selection we'll talk about a little bit more. So the transducer and the preset are both going to be based on the type of exam that we're performing. These are the presets themselves are going to be the combination of settings that the manufacturers of our equipment have decided are most optimal when we're scanning specific body regions. So our curved probe, you can use a transducer to scan anything, right? But whether or not it's going to be the best transducer to use for that type of body part is going to be subjective. So the presets are going to be under pretty much every transducer. There are also certain cases where we don't use the standard transducer for that particular exam, maybe because of patient body habitus, maybe because of some other kinds of complications going on. So we'll talk about those things as they come up. But transducer selection, preset selection, these are going to be what the manufacturers of our equipment have deemed to be appropriate based off of what we are looking to scan. With our preset selections, we also get specific measurement packages that come with the specific preset. So for an example, we have a gynecology exam that we can do. We use a curved transducer. We use a gynecology preset. And then when we select that gynecology preset, it's going to populate specific measurements that they know we have to take during that exam. So it's going to give us specific length measurements, height, width measurements, volume measurements. Those are all going to pop up when we go to measure something during that exam. So it saves us a little bit of time. And then our abdominal preset is going to be very similar with those measurements. So it knows we have to take specific measurements of our liver, of our kidney, of our spleen. So all of those things will be correlated with those specific exam presets. So now we're ready to perform our exam, and you have to be aware that we can't just go in and take pictures however we want. We have to follow specific protocols that are usually going to be very similar amongst facilities. So there might be some differences, some kind of minor changes between protocols, but for the most part, the root of our protocols are going to be set by the ACR and the AIUM. So you should remember that from our very first PowerPoint. Here is our report page. So we've gone through our entire exam. We've taken all of our pictures in an appropriate protocol. We said we were going to be doing an abdominal exam. We used the curve probe. We used the abdominal preset. So when we went to take certain measurements that are required in our protocol, here is where they popped up. So here is our report page that we take at the end of our exam that says, okay, I got all my pictures. I know I got all of my pictures. Now I can double check and make sure all of my measurements went through. So here we can kind of see everything that was saved during our exam. And just like that patient ID page at the very beginning of our exam, we're also taking a picture of this page. This is where our radiologist is going to go, and they're going to use these measurements within their report. Next, we have our image check before we send our patient out, before we end our exam, before we do anything. As soon as we finish our exam, we double check. So we make sure we have all of our appropriate protocol pictures. We make sure that those pictures are high quality. So when you go back and look at them, you may say, oh, I really struggled to get a picture of the pancreas. Take a moment, go back, see if you can get a better picture of that pancreas. The patient's not going to get mad at you for trying your best to get the best pictures possible. Make sure that you're deleting any pictures that are not high quality or maybe they're not appropriate, and you are retaking them as necessary. So patient interaction when we are leaving, you want to make sure you ask the patient if they have any questions for you. They're usually always going to say, did you find anything? And you cannot say anything. So you will let them know who will contact them if you did or did not find anything, who will contact them with the report. Typically results go over to their doctor. So they go from our doctor writes the report. It gets sent electronically to their doctor, typically within 24 to 48 hours. So you want to instruct your patient to communicate with their doctor regarding results of the exam. You can then have your patient change back into their clothes if they did, and dispose of any gowns and linens. If we are working in an outpatient facility, chances are our patients are walkie-talkies, meaning they're able to walk on their own, they are able to talk on their own. So usually they are able to clean up after themselves. So you want to show them where they can put the gown after. We typically have linen bags in the room, so ask them to put the jelly towels in the linen bag for you. Ask if they need help changing, and of course offer that help if they do. Allow the patient to use the bathroom before leaving, so just show them where the bathroom is. If the patient doesn't need to wait for the radiologist, then you can communicate that they are all set to leave. They typically will do a lot of their paperwork up front when they check in, but make sure that all of that paperwork is completed with the front staff. If it's not completed, have them go back up to the front desk with the secretary or receptionist. And if it is all set, you can then show them how to leave the department. If your patient seems confused or disoriented or kind of unstable, make sure you have them sit and wait. You want to make sure that you are not sending your patient out to, like walk around the hospital aimlessly because they're confused or they're lost. You also want to make sure that they are feeling okay. There are some exams where our patient has to lay down for quite a while, and then they get up and they're very disoriented. Their blood pressure is all over the place because they were laying down for so long, and then they got up really quickly. So you want to make sure that they don't faint anywhere else within your facility and that you get them where they need to go. Next, we're going to do our room breakdown. So we're going to go back in, make sure everything is thrown away. So we're putting all of the dirty linens in the linen bag. We're using PPE when we're doing that. It's just put gloves on. When in doubt, just put gloves on. We need to use clean gloves to clean the transducer. So what I like to do is I put just one glove on one hand and I clean out all of the soiled linens into the linen bag. And then I use another glove on my other hand to clean the transducer. You want to make sure that you're not wiping the transducer down while it has massive globs of gel on it, because that's not going to clean the transducer. So wipe off all the excess gel with a clean towel, not the towel that the patient used. Use a designated disinfectant wipe or spray, depending on what they have in your facility. And you want to make sure that you're allowing for wait time. So a lot of these really high-grade disinfecting wipes have a turnaround time on them, typically between 2 to 3 minutes, so that it needs to completely dry. You also want to make sure you're cleaning the ultrasound machine, getting any globs of gel off the machine, cleaning those highly used control buttons off, making sure it's nice and presentable and sanitized for the next patient. You then want to make sure your machine and your table are back to the initial starting point, getting ready to go for your next patient. So bring that exam table all the way back down again for your patient to get on it, have clean linens ready to go, and make sure your room is nice and orderly. Here are our disinfecting wipes. So you're going to see a variety of these out in the clinical setting. Typically in ultrasound rooms, we are using the purple, gray, and green top wipes. The Cavi wipes, the ones on the left-hand side, these were kind of like the old school wipes that we were using for our transducers probably like 5-10 years ago, but they're kind of getting phased out. They're using these a lot kind of for surface structures. So, to disinfect like a tabletop or disinfect like, doorknobs, light switches, those things. But we're not really using them as much for transducer and machine cleaning. We are using a lot of the purple, gray, and green, like we said. We do have purple at the school. Purple is what we should be using for really any kind of surface. The problem with purple wipes is that it can discolor certain plastics. So if we use the purple wipes, we want to make sure that we're not using them to clean a lot of the cord on the transducer, and that we're not using them to clean the machine. They can discolor. So we don't have any at the school, but we try to use the green wipes because those are a little less, they cause a little less discoloration on the cords and on the machine itself. So you'll see a lot of facilities kind of have the green wipes, and same thing with the gray. They're all just different combinations of chemicals. They're all very strong and potent, but they can have discoloration on the machines, so just be aware of that. The red top wipes, these typically will have bleach in them, I believe. We don't really use these on ultrasound machines because it can damage the transducer surface. The blue wipes, these are going to be the only wipes that are okay for patients to use on their skin. It's kind of just like a hand sanitizing wipe. So you're going to see a lot of the purple, gray, and green. Again, be cautious with using these wipes on the soft surfaces of the machines. So these can be used for the exam table. They can be used for the plastic chair that you sit on. They can be used for the top part of the transducer. We just want to avoid deep cleaning the machine itself and the cord with these. We typically will have another spray that we can use for those surfaces, just because those plastics are a little soft. So tips for beginning scanners. Make sure you are starting off slowly. You're scanning slowly. You're going through your checklist slowly when you're first starting an exam. Make sure that you are changing your motions one change at a time. So we're not taking the transducer and scanning all around the patient's belly. We're doing little tiny motions, different positions, different windows. We're doing everything one at a time, slowly, seeing how that change affects your picture. You want to make sure that you're experimenting. So if you're struggling with one thing, you try something else. You want to make sure that you are watching your screen and that you begin to learn to trust your hand. Let your hand do what it needs to do. Your hand is going to go through those motions, but if you're watching your hand, you're not seeing what that movement of your hand is doing on the screen, and that's the most important part. You have to be watching the screen and see how slow those movements are affected. See how much better or how much worse certain experiments are when you start changing your position. Have your patient try different breathing techniques. I say it until I am blue in the face every year, but you guys have to ask each other to take big breaths. And I mean big, big breaths. We're making pot bellies in lab. So please make sure that you ask your peers to take a big breath in and hold it. It makes a massive difference. Make sure you're establishing a routine and you're following it. You're building that routine. It's going to become habit to you over time. Everything feels so foreign right now. Everything feels so new right now that you're like, how could I possibly build a routine when I have no idea what I'm doing? But I promise you it will slowly fall into place as we keep scanning. You also want to make sure that you're taking additional pictures, especially if you see something that you're not sure of. When in doubt, take more pictures, because you can have people critique you on more. If you only take one picture of a pancreas, I can just tell you if that one picture is good or bad. But if you take 15 pictures of a pancreas when you're first starting out, then I can say, okay, this one is a little bit better than this one because, right? Or, oh, this one's really good because you see how this happened when you went from this picture to that picture. We can use comparison to help us when you're taking a lot of pictures. Now, I say when you're first starting out because I don't want to hear a year from now, when you guys have been in clinic for 9 months, that you're taking 42 pictures of one organ. So we're going to find that sweet spot. But when you're first starting out, and especially in lab, more is better. Basic transducer manipulation. So make sure you are comfortable and relaxed. We don't want to be gripping the transducer with all of our might. We want to make sure that we are in a situation that is allowing us to think freely. So you're comfortable, you're relaxed. You're holding the transducer at the base and you're resting your hand and your arm on your patient whenever possible. That's going to help you stay relaxed and be comfortable. You want to sit to scan when necessary. Now, some of you are really, really tall. Some of you are on the shorter side. So sitting may not be, it may not be helpful for you guys. So we're going to work on a one-on-one basis and we're going to see what works for each of you individually. We're going to be making sure to look for optimal windows for scanning. So if one approach isn't working, we're going to learn what another approach could look like. Make sure that you are staying dedicated and you're not getting frustrated with the process. A good technique, good images, good practices, good routine, good habits, they all come from practice and dedication. It takes time. Nobody comes into this being great, right? So please don't get frustrated with the process. You are probably going to want to compare yourself to your peers, and I promise you that is going to do nothing in terms of benefit for you. So do not look at what your other peers are excelling at. Do not think about what you are struggling with. It will come. Your main focus is to communicate, ask questions, really try to pay attention, absorb and observe as much as possible. Even when you guys are the patient with your partner, you can still watch that screen. You can still hear what I'm trying to tell your partner to do. You can still watch what I'm having your partner do. So even when you're the patient, you can still be absorbing all of that information that's going to help you out when it's your turn to scan. Certain techniques. I do have some videos on the next slide that you guys should be watching. They give a great representation of certain movements that I'm going to tell you to do in lab. So sliding, this is going to be when we are really kind of just moving that transducer, you know, from one area to another. It can be done in any direction. It's kind of a broad term of just gliding that transducer on the patient. Rocking is going to be where we're angling that transducer to a point and away from it. You're going to hear me say heel toe. So think about when you're like going up on your toes and then back on your heels and up on your toes and back on your heels. Your feet are kind of doing this rocking motion, just like a rocking chair, and that's exactly what we're going to have our transducer doing. We're going to angle towards something, we're going to angle forward and down to something, and then we're going to angle up and back and away from something. So literally like a rocking chair. Now tilting, this is going to be when we're angling the transducer from side to side, whether we're in sag or we're in transverse. We're going to be kind of going side to side with that, sweeping side to side or sweeping top to bottom. And then compression, that is when we are physically pushing down on that transducer. We're applying pressure to that area. It's going to really, really help us. I'm sure when you are the patient in lab and I am helping your partner, you feel the difference in pressure when I am scanning you versus when your partner is scanning you. We need pressure while we're scanning. I promise you, you're not going to hurt your patient. And even if you give a little bit of discomfort to your patient, you want to make sure that you're just communicating and saying, I'm really sorry if this hurts in this area. I just have to push a little bit harder to get this picture. If you want me to stop at any time, you just let me know. Okay, but patients can tolerate more than we think they can, and they will communicate if they want to stop or if something is too uncomfortable for them. We also use compression to help us diagnose very important and emergent conditions. So blood clots, we use compression to help us find, and then also in emergent clinical symptom of a gallbladder that could potentially be on the verge of rupturing is called a Murphy sign. So we use compression to help see if there is a Murphy sign with a patient's gallbladder or not. So we're going to learn that pressure is important, and your pressure will start to increase over time as you become more comfortable scanning each other. But I'm sure you guys have noticed the difference of when I scan you versus when your partner scans you. And that's going to be a big difference in the quality of your pictures. So here are the links to watch the different kind of visualization of the transducer techniques. So if you have any questions about these, please do not hesitate to ask. And then you can jump right into your knobology lecture. We're going to be talking about those controls much more in depth.